Hello, this is Dr. Amin Marashi and a specialist in Marashi Eye Clinic in Adipose, Syria. I am presenting the course of Structural EnFace OCT, and in this presentation I will present the findings of the Structural EnFace OCT in Bruch's membrane choroidal vascular diseases Part 1. In non-neovascular age-related macular degeneration, the geographic atrophy appears as increased reflectivity of the choroid due to RPE absence to reflect the light. Hence, the EnFace OCT in the choroidal slab will exhibit a hyperreflective patch at the geographic atrophy area. In contrast, the RPE slab will show a mild decreased reflective patch at the area of the geographic atrophy. EnFace OCT can be a valuable imaging tool to evaluate the non-neovascular changes at different levels. It will show drusen in a manually segmented layer, then geographic atrophy in a choroidal layer. EnFace OCT can be very precise in detecting and monitoring geographic atrophy growth, especially in subtle cases of incomplete retinal pigment epithelium and outer retinal atrophy, or nascent geographic atrophy. The slab segmentation at the level of inner segment outer segment junction will show areas of decreased reflectivity, which indicates disruption of this layer and may aid in the future progression of geographic atrophy, as there are similarities between geographic atrophy sizes, location, and changes in the structural EnFace, which appears hyperreflective, and fundus autofluorescence, which appears hypoautofluorescent. Harder drusen features small hyperreflective punctiform spots. Softer drusen will appear as a hyperreflective uniform boundaries with central medium to hyperreflective changes in the RPE slab, especially in slab 20 microns below the RPE layer. When the slab is manually adjusted, drusen will appear as hyperreflective patches with hyporeflective background due to the adjusted slab is passing through the outer nuclear layer and RPE elevation. But the OCT EnFace not always reliable ancillary test to quantify drusen. In contrast, the adjusted slab can detect regressing drusen with hyperreflective content, which will appear as a hyperreflective circle with hyporeflective content. The drusenoid RPE detachment will appear on EnFace similar to soft drusen but with a larger diameter. However, the EnFace OCT can accurately determine the extension and size of the RPE drusenoid detachment. At the same time, intraretinal pigmentation will appear as hyperreflective foci in the IPL-INL slab. Please note blink artifact. EnFace OCT can show changes in the number and sizes of drusen in the follow-up, as shown in this example of progression of drusen 1 year later, and the progression was witnessed on EnFace as well. The subretinal scar is not easy to identify by default, as it will appear as hyperreflective mass over hyperreflective RPE slab. To easily identify it by adjusting the slab, a subretinal scar will appear as hyperreflective consolidated mass and borders, and can be associated with more thin hyporeflective contours. Outer retinal tubulation will show a tubular network of branching tubulus in a segmented slab. Thus, EnFace OCT can be used to differentiate between intraretinal cysts, subretinal fluid, and outer retinal tubulation. In cases of neovascular age-related macular degeneration, the macular neovascularization type 1 will appear on RPE slab as hyperreflective mass with irregular hyperreflective borders surrounded with hyperreflective pockets due to subretinal fluids in active cases, and the sizes of these pockets depend on the size of subretinal fluid and slab segmentation. The choroidal slab will show hyperreflective material from the segmentation line crossing some area of the RPE. However, some cases can reveal the neovascular network surrounded by irregular hyperreflective borders if the segmentation line was adjusted just below the RPE elevation. Here are some other examples. The content of the pigment epithelial detachment can be varied depends on the level of the segmentation. In active cases, the inner plexiform inner nuclear layer slab will show hyporeflective cysts resembling intraretinal cystic formation. In macular neovascularization type 2, the RPE slab will show a hyperreflective amorphous subretinal fibrovascular membrane with more defined borders surrounded with hyporeflective pockets of subretinal fluids in active cases. The sizes of these pockets depend on slab overlay adjustment and size of subretinal fluids. In active cases, the inner plexiform inner nuclear layer slab will show hyporeflective cystic spaces resembling intraretinal cysts. EnFace OCT can be helpful in providing a pan view of the neovascular lesion and structural changes in different levels that help to identify structural changes that may be missed in routine OCT scan inspections. EnFace OCT can be useful in following up the neovascular lesion size, number, location, and activity post-treatment. It can identify coexisting pathologies such as vitreomacular interface abnormalities and pachychoroid. Hence, EnFace OCT can be used to assess the size of subretinal fluids and fibrovascular membrane along with coexisting intraretinal fluids pre and post treatment. As post-treatment slabs may show resolution of the intraretinal and subretinal fluids with shrinkage of the subretinal fibrovascular membrane. One key difference between the OCT angiography EnFace and the structural EnFace OCT is the former will show neovascular network while the latter will show a fibrovascular membrane. In macular neovascularization type 3, the EnFace OCT will behave differently according to the stage and segmentation level. In stage 3, the EnFace OCT on the RPE slab will simulate somehow the macular neovascularization type 1, but when adjusting the segmentation toward the hyper-reflective material level adjacent to the pigment epithelial detachment, the EnFace OCT will reveal hyper-reflective material with a more defined border and can be close to the retinal vessels. Thank you for listening. Please visit my website www.amretina.com where you can find more online courses and online guidelines.